We have the next case coming up. It's our convener, Dr. Swetha. She is going to speak on Phaco in small pupil without any devices. Yeah, over to you.
Good morning, everyone. So today my topic is Phaco in small pupil without devices. So there are a plethora of devices available in the market, as you all know. But when would you want to perform Phaco in a small pupil without devices? Either when there is a non-availability of devices or due to cost factor, or when the pupil is not very small and you don't want to use a mechanical device because every device causes some amount of sphincter damage. So small pupil is defined as a pupil size of less than 6 millimeters. So what are the risk factors? Pseudoexfoliation, diabetes, chronic uveitis, trauma, prior ocular surgery, prolonged use of myotics like pilocarpine, floppy iris, high hypermetropia, and so on. So the complications include damage to the sphincter, iris chafing, PC rend, nucleus drop, and also because of the prolonged surgical time, there can be AC inflammation, endothelial damage, and so on. So the difficulties associated, all the steps become difficult because there is a difficulty in visualization because of the decreased red glow. And also there is a decreased working space because of which there is difficulty in maneuvering. So the outcome depends upon the biomechanical properties of the pupil, that is whether the pupil is, the iris is floppy or not. So if it is a floppy iris and the pupil size is less than 4 millimeters, it is better to go with the device in the first place because the pupil size tends to come down further while performing the surgery. Again, the density of the cataract, that is very hard and very soft cataracts, can be difficult to manage in small pupils. And also the surgeon's experience matters. So preoperatively do a thorough slit lamp examination and rule out comorbidities like shallow anterior chamber, corneal guttae, or any corneal opacity. So we tend to give NSA drops like bromphanac 3 days prior to surgery because it helps in dilatation, and also use tropicamide plus prior to the surgery. Intraoperatively, you can use pharmacological agents like adrenaline, either intracamerally or you can mix it in the irrigating solution. And nowadays we have newer fixed dose combinations like phenocaine plus, which is supposed to provide sustained dilatation throughout the surgery, but I really don't have experience with that. So before doing a dilatation, it's important that you it's not playing. Yeah. So always remove the synechiae before proceeding with the surgery. So this is a case of angle closure glaucoma with a history of prior trabeculectomy. As you can see, the synechiae are being released under irrigating solution because once you inject visco, as you all know, the staining of the capsule will not take place. Um, Viscomydriasis. So always use a viscoelastic agent like Helon 5 because it will give you another additional 1 to 2 mm of dilatation. And also you can use a viscodispersive like visco to coat the endothelium using the soft shell technique. Next, capsulorhexis. So capsulorhexis, always use trypan blue to stain the capsule, especially if you're a beginner because there is already a decrease in the red glow, and it will help you in the completion of the rhexis and the visualization. So the size, this is a case of brown cataract. So this is a case of brown cataract, and here you can see the rhexis is being performed with an Utrata forceps, and always aim that the size of the capsulorhexis should be equal to or slightly larger than the pupillary size. Coming to hydrodissection, always perform a gentle hydrodissection because if you inject a large wave of fluid, it tends to irritate the iris. tends to irritate the iris, and that will cause further constriction of the pupil. So inject multiple small waves of fluid in several quadrants and look for forward movement of the nucleus to ensure a hydrodissection has been done. Next, coming to phacoemulsification, this is a case of mature cataract with around 5 mm of dilatation. And if you're a beginner, it is always better to perform the surgery under a peribulbar block. As you can see, there is a central trench which is done, and the nucleus is being chopped by vertical chop into several smaller fragments. And it is important that you stay in the center of the pupil, and before emulsifying the fragment is always brought to the center, because that is where there is maximal working space. And the parameters can be more or less maintained like a regular cataract as long as the iris is not floppy, because in a floppy iris you will have to decrease the parameters. This is a case of So this is a case of brown cataract with around 4 mm of dilatation. Here a central crack is being made using a modified stop and chop technique. And the nucleus is further divided into smaller fragments using a horizontal chop. And the basic rule remains the same: make it into as many smaller pieces as possible, and always bring the fragment into the center before emulsifying it. Next, this is a case of floppy iris.
A minute there, huh?
Done. So this is a case of floppy iris. Here the wound construction is very important, because already the iris tends to prolapse throughout the case, and you have to take parameters slightly at the lower level, because there will be a lot of turbulence in the anterior chamber, and the tissue tends to come towards the phaco probe. And in case the dilatation comes down midway through the surgery, you can always inject a viscoelastic through the side port for further dilatation. And in case the dilatation does not increase when you inject a viscoelastic, you can always use a dilating device. So cortex aspiration, it's always better to use a bimanual irrigation and aspiration system, because you will be able to lift the iris to visualize the cortex, and that will ensure a complete removal of the cortex. Coming to IOL implantation, always make sure that the leading probe goes into the bag, leading haptic goes into the bag, so that you ensure an in-the-bag placement of the IOL. Visco wash, thorough visco wash should always be performed, because a lot of visco tends to be trapped behind the iris because of the small pupillary size, and also the visco behind the IOL has to be removed. So conclusion, safe surgery is always the priority, and don't hesitate to use devices when needed. Thank you.
Very nicely depicted. A small tip for those who have just seen how she is doing with the forceps. Don't press the posterior lip, otherwise there will be egress of the viscoelastic, shallowing of the anterior chamber, and there will be a run through.